Thank you very much for giving us this opportunity to present the findings of our study. Vaginal delivery is an important etiological factor in pelvic floor dysfunction. One of the pathophysiological mechanisms seems to involve trauma to the levator ani muscle, which has been reported to occur in 10 to 36% of women after vaginal delivery. It is common, however, the condition is often not diagnosed at delivery suite because it is commonly occult. The aim of the study was to determine whether perineal tears, in particular third and fourth degree perineal tears, and vaginal tears are clinical markers for levator trauma as diagnosed using tomographic ultrasound imaging at 3 to 6 months postpartum. This is a retrospective study using data obtained in 2 perinatal trials. The data of 774 women who had been seen after first birth 3 to 6 months postpartum were analyzed. The assessment included a standardized interview, a clinical examination, and 4D transperineal ultrasound examination. Clinical data were obtained from the institutional obstetric database. For doubtful cases and for those diagnosed having a vaginal tear, the medical record were reviewed to determine the location and the extent of the tears. Levator avulsion was diagnosed on post-processing of archived ultrasound volume using tomographic ultrasound imaging 3 to 6 months postpartum, blinded to all clinical data. This slide shows you a patient with a right-sided levator avulsion. This is in the axial plane. Imagine you're looking up between the patient's 2 legs from the bottom. Using tomographic ultrasound imaging, a set of X lines is obtained. Levator avulsion is diagnosed if there is an abnormal muscle insertion on the os pubis in one or both sides in these 3 central sides. This is our reference plane. This is the plane of minimal height dimension identified in the mid-sagittal plane, where the distance between the pubic bone and the anterior part of the levator ani muscle is shortest. Levator avulsion is diagnosed if this reference plane and 2.5 centimeter and 5 centimeter cranial to this reference plane show an abnormal insertion. This lady has got a right-sided levator avulsion, as you can see that the abnormal muscle insertion is marked by an asterisk. Out of the 774 women, 53% of them had a normal vaginal birth, and 12% had a von Toos delivery and 6% a forceps. 84% of them were Caucasians, and here shows you their demographic data. 86 patients had a mediolateral episiotomy. In our centers, episiotomy was performed selectively. 266 patients had a perineal tear. Out of them, 32 of them had a third and fourth degree perineal tears. 94 patients had vaginal tear, with 24 involving the lateral side wall. Levator avulsion was diagnosed in 83 patients, which constitutes about 15% of all the vaginally paris women in this study. This table shows you the association between the diagnosis of levator avulsion on tomographic ultrasound imaging with a mediolateral episiotomy, various degrees of perineal tear, and different types of vaginal tear. There was a significant association between a diagnosis of avulsion with episiotomy, third or fourth degree perineal tear, side wall vaginal tear, and labial tear on univariate analysis. And this column shows you the odds ratio. On multivariate analysis, after controlling for maternal age, baby weight, second stage length, as well as BMI, the association between vaginal side wall tears and third or fourth degree perineal tears remained significant. The odds ratio was around 3.4. So in this study, both third or fourth degree perineal tears and vaginal side wall tears are found to be significantly associated with the diagnosis of levator avulsion. The association may be explained by common risk factors, for example, first vaginal birth, advanced maternal age, and forceps delivery. When such facilities exist, these clinical markers may be regarded as an indication for postnatal pelvic floor imaging to allow diagnosis of levator trauma. The strengths of our study include its large database of 774 patients. Our methodology for diagnosing levator avulsion has been validated against symptoms and signs of pelvic organ prolapse and has been shown to be highly repeatable. We have confirmed previous findings of an association between levator avulsion and third or fourth degree perineal tears. Our study has also shown that vaginal side wall tears is also a clinical marker for levator avulsion. Our study, however, is limited by its retrospective study design, and therefore the quality of medical documentation was not controlled. The results may not be applicable to other ethnic groups, as our population is consisted about 84% of Caucasians. The findings are likely dependent on local obstetric practices. For example, the forceps rate and the type of forceps that is used, the type of episiotomy, whether it is midline or mediolateral, as well as whether it is selective or routine. In conclusion, vaginal side wall tears and obstetric anal sphincter tears are independent clinical markers for levator trauma as diagnosed by tomographic ultrasound imaging at 3 to 6 months postpartum. Such markers may become useful in the identification of women at high risk of levator trauma and future pelvic floor disorders. Thank you for your attention.
This paper is open for discussion. Big compliments for your study. It's very interesting to find out more and more what the consequences are for the delivery. If I look at your data, we should ask for episiotomies all the way.
Sorry.
If I look at your data, we have more avulsions if there is no episiotomy, while women are so very proud they deliver without having an episiotomy.
Well, we have to be cautious about the use of episiotomy to prevent levator avulsion. In our centers, episiotomy is performed selectively. That is to say, when the birth attendants anticipated there might be problems, for example, prolonged second stage fetal distress or a difficult labor. So it is difficult to determine whether episiotomy itself is protective against levator avulsion. It may be different if we do it routinely.
So you have somewhere in your data the information why you did the episiotomy to have this more analyzed in future? Because I understand your selection of having this episiotomy.
I think we have done a study looking at the association between routine episiotomy in our centers and levator avulsion. In that study, we actually didn't find any negative or positive effect of episiotomy on pelvic floor trauma.
Okay, thank you.
Routine. Of course, it's not routine, okay? It's selective. And on multivariate, the effect disappears. So the jury is definitely out.
Thank you. There are no more questions?
I have one question.
Okay.
Do you believe that the third or fourth degree of perineal tear and the vaginal side wall tear could predict the patient who are indicated the early approach of physical therapies to avoid the pelvic floor muscle disorder?
Yes, I think these are clinical markers. If we have limited resources, these are clinical markers that can help us to identify women who are at risk of pelvic floor trauma and at risk of future pelvic floor dysfunction. And we should then refer them to pelvic floor physiotherapist, because this is what they need to prevent them from having future problem.
Okay, thank you. If there are no more questions, we can go on.
Okay, move on.